Hi everyone, welcome to this evening's webinar with Dr. Qaiser Malik. So we're going to be talking a little bit on MRI and ultrasound and which modality to refer for in just a few minutes, and I'm just going to introduce us as a company. So my name's Neve, I'm the events coordinator for Oryon Develop. So obviously we do CPD courses for AHPs and the public as well. So please get involved and have a look at our course pages. We're going to be doing some interactivities and putting some buttons up left, right and centre. So if you want to click those, please do. So we're going to be doing this talk in conjunction with Oryon Imaging, and that is our other part of the company, which is our medical imaging centre. It's in the Harley Street area, it's Wimpole Street. We've been operating a really safe service throughout lockdown with PPE for staff and for patients. And we're currently operating full service pretty much. We've got MRI, Xray, ultrasound and DEXA all running. And obviously we're going to be talking a lot about MRI and ultrasound in this talk. So if you do want to refer to us, we'll get you involved in that, and we'll do some things at the end in case you want to refer to us. So we also have Oryon Connect, and this is our service where we have trusted clinicians and we get patients the right clinician for their problem. And for both imaging and Connect, we have an online service which is secure, and that's where you can share your images with the patient and also the report if you choose to do so. So yeah, we're going to be doing some polls and other things, so please get involved. If you've got any issues, please click the little hand symbol on the bottom right. My colleague Gareth will privately message you and his name will pop up in the top of the chat box, and we will try and sort out your problem. We're also going to be doing a Q&A at the very end, so if you've got any questions throughout, just put them in the chat box and we'll get to them right at the end. Okay, so I'm going to hand back over to you, Qaiser, and we'll get started.
Thank you very much. Hello, everyone. My name is Qaiser Malik, and I'm coming to you from my study here. So normally, I would be presenting this at the lovely Oryon offices, and obviously I'd have an audience in front of me. But unfortunately, I don't get to see you, but you get to see me, which is all good, I guess. So my name is Qaiser Malik. I'm a consultant radiologist, and I work at Oryon. I've been working at Oryon for more than 10 years now, and I have seen the company and the organization grow. And I think the way the organization has handled the recent coronavirus pandemic is actually second to none. We stayed open throughout the whole period, and provided a really essential sort of imaging service throughout the whole pandemic in a very safe and a very nimble sort of way, keeping abreast of all the guidelines and everything else. Obviously, as Neem mentioned, we're now back up running with terms of MRI and ultrasound and plain X-ray as well, and DEXA scanning as well. So my name is Qaiser Malik. I'm a consultant radiologist. I work in and around London in various places, and I also am the clinical director of radiology in Essex, looking after the radiology department across 3 trusts: Basildon, Chelmsford and Southend. I'm responsible for the whole of those 3 departments, a combined sort of budget of about 47 million, 60 radiologists, 500 staff, 9 CTs, 9 MRIs, I've lost count of how many ultrasound machines, and X-ray machines. So, and because of that role, I kind of understand where radiology fits into the patient pathway. And that's what today's talk is going to be about, sort of which modality you choose for when, where is the overlap, how you make that decision, and how you get the best out of your radiology department or your imaging center that you're using so that you can really add value to the patient, to the service that you're providing, and really make it worthwhile and actually get the maximum benefit for the effort that you're putting in terms of from an imaging perspective. So we're going to talk about various tests, their role in the pathway. We're going to talk about the different modalities that are available to you as clinicians. We're going to talk about when to refer to what modality, how to write a really good referral so you get a good sort of report back. No point getting a scan done if the report is all gobbledygook. And we're going to talk about, and then we're going to have a short break. And then after the break, what we're going to do is I'm going to actually show you some live cases. We're going to go through some images, go through some scans, and look at the scans, look at the images, look at the findings, and then talk about how we communicate those findings to the patients and some of the things that you can do. So there are a number of tests available in a average radiology department. You've got your plain X-ray, which is a workhorse, obviously, lots and lots of X-rays being done all around the world all the time. Ultrasound, which is a very key modality. CT, which has been around for a long time now, and I'll talk a little bit about CT. And MRI, obviously, for soft tissue, musculoskeletal, neuroimaging. And then there's some special sort of studies. So your functional imaging, PET CT, SPECT, where what you're doing is not just imaging the body where you're trying to get an anatomical representation of what's going on, you're actually adding in some functional information as well. So you're getting in the bits of information around how active a particular finding is, and whether there is increased activity, which could indicate, for example, a neoplastic cancerous lesion. And of course, there's the specialized CTs, for example, cardiac CT, cardiac MRI. I see a few people are saying they can't hear me. Do you want me to stop while that's resolved? Neem, can you?
It's okay. My colleague Gareth will privately message you.
Okay.
So yeah, just keep an eye out for his name at the top of the chat box, and he'll resolve the issue. And any problems, you can always catch up with the recording, which will be sent out by email tomorrow.
Fine. So I'll carry on. Excellent.
Yeah,
so specialized CTs like cardiac CT and cardiac MRI are obviously new areas where imaging is making a big difference. Right. So let's look at.
Sorry, should we do the first poll?
Oh yes, let's do the first poll. Right. Before we get cracking, this is a good idea. So I wanted to know what we're going to ask is going to get you involved, so no one gets to sleep and then come back and get their CPD points. So you have to work your way through the polls during the presentation. So which scan is better? Okay, is MRI better or is ultrasound better? So how does it work, Neem? What do they have to do?
They just have to click. You might have to scroll down if your screen's quite small on the voting, but you should just have two options, MRI and ultrasound. Select your favorite, and we will
we'll tell you your results.
Yeah, we'll give them 30 seconds.
Yeah, we'll give you 30 seconds. Yeah. So which is better? If you had a choice and money and accessibility were no object, which would you choose? An MRI and ultrasound scan? What would you like to have done?
So we'll give you 5 more seconds and we'll stop the voting there.
Okay, good.
So there's the results. Most people said MRI.
Excellent. Okay, good. Well, I might ask that question again at the end. Okay, so we'll bear that in mind. Let's move along. Okay, so let's have a little bit of background with regards to imaging. So as a radiologist, I've been a consultant for 10 years, and I've seen a phenomenal increase in the demand for our services. So we are seeing a 10 to 12% increase year on year in terms of demand, and that's across all modalities, particularly in the complex modalities. So CT and MRI are seeing continuous growth year on year. And this pretty much is unsustainable in terms of the sort of the layout of the healthcare providers, whether that's in the private sector or in the NHS, to be able to have that much demand and to be able to deliver that in a safe and efficient way. It's becoming unsustainable, particularly in the National Health Service, where there are limited resources. And obviously with the recent pandemic, when we basically stopped all routine work for 3 months, we are now in a real sort of real dire situation where we're trying to claw back a backlog. We've got hundreds and if not thousands of patients waiting for scans, and we're still getting the ongoing demand coming in at the front door. The private sector is obviously very useful in this because it means that people can get scans accessible. Places like Oryon are really good because it does a number of things. Number one, it makes imaging affordable and accessible for patients because it's not extortionately expensive, and also it's accessible in the sense that the referral pathways that we have in place make it very easy for patients and for clinicians to access imaging and then make a difference to their healthcare. And the private sector ultimately helps the NHS. The more we can offload the National Health Service and do healthcare in the private sector, the less sort of burden that will have on the National Health Service. So let's go through plain X-ray. Obviously, it's the workhorse of any imaging department, and we do plain X-ray at Oryon Imaging. It uses ionizing radiation. So essentially, what happens is the patient stands in front of a detector. At the other end of the room, there will be a sort of an X-ray machine which will produce X-rays. Those X-rays will fly across the room, hit the patient, and then depending on which organs they hit along the way, will come out of the other side onto the detector, and then the detector will form an image. Been around since 1800 or so, invented by Roentgen, and basically you get very good images, and really is a very cheap, accessible form of imaging. There are a lot of regulations around X-ray because obviously you are giving a patient radiation. So radiation is harmful. We are all exposed to radiation all the time in our everyday lives, walking around, flying. You always get a certain amount of background radiation. So for example, a chest X-ray is equivalent to 3 days worth of background radiation. A CT scan would be equivalent to like a year's worth of radiation. And I'll come on to radiation later. The problem with X-ray is that you get no soft tissue characterization. So you don't see any of the soft tissue injuries. What you'll end up seeing is bony abnormality, bony fractures and things like that. It's very, very useful in chest. So obviously something that we've seen very useful in the current pandemic. We're doing a lot of chest X-rays, and it's very good for appendicular skeleton, so fractures and rheumatological conditions. Moving on to ultrasound. Okay, so the ultrasound has a massive advantage over X-ray in the sense that there's no radiation. So it's extremely safe. Otherwise, we wouldn't scan pregnant women. We wouldn't be scanning fetuses if it wasn't safe. It's very, very accessible. And it's very cost effective. It's not an expensive test. The machines that we use to do the ultrasound themselves are relatively cheap when we're talking about comparing them with CT and MRI scanners, for example. And it's got a massive advantage as a radiologist where I actually get to interact with the patient, which I don't do that often because most of the time I'm looking at scans. So it's very good for me as a clinician to be able to provide a dynamic service. So I can actually ask the patient, where is the lump? Where is it worse? How does it hurt? Which movement makes your shoulder hurt, for example? And then use my ultrasound to be able to guide to that point and make the patient do that action that will give me potentially answers. So that's something that, for example, you cannot do an MRI. There's Achilles tendon, for example, an Achilles tendon tear. There's no way in an MRI will be able to tell you if the two ends are going to come back together in plantar flexion, unless you scan the patient in plantar flexion and then scan the patient again in dorsiflexion. You can't get that answer, and that would take maybe over an hour to do on an MRI scan, whereas that will take literally 5 minutes on an ultrasound scan to do that. The downside to ultrasound is very operator dependent. So it depends on who's doing the scan. So for example, if it's MSK trained musculoskeletal radiologist, they're going to give you very, very good reports and very good images for ultrasound. We're looking at musculoskeletal problems. However, if there's somebody who doesn't do that much MSK, then for them to be able to really delineate all the structures and work out the anatomy and the pathology is much harder. Whereas obviously something like MRI or CT is much more you can replicate a lot more easily. And the images that are acquired during ultrasound cannot really be deciphered by a non-operator. So it's usually the person who does the ultrasound that will basically provide this report, because they're the person who can actually identify what's happening and be able to decipher that. So it's easily available, it's low cost, it's dynamic. You can compare the normal side. That's something that I do all the time. For example, if I'm looking at an Achilles tendon for tendinopathy or patella tendon, for example, I'll scan the normal side It's very useful because it gives me an idea of what normal looks like for that patient. It also gives me a lot of buy-in from the patient, because when you're telling the patient they've got something and you show them what the normal side looks like and what the abnormal side looks like, they really get that what you're saying, it makes sense, and they're more likely to adhere to any therapy that you may or may not want to give to them, because they'll understand that there is a problem and they've seen it with their own eyes. When is it used in terms of MSK? Muscles, tendons, ligaments, and joints. We do use obviously a lot of ultrasound in abdominal scanning. So, for example, in the abdomen, so liver, spleen, pancreas, kidneys, all of those organs can be easily assessed using ultrasound. Gallstones, for example, and even the vessels. So, for example, the abdominal aorta, the peripheral vessels, looking for DVTs and such like. So it's lots of use, and obviously, as I mentioned, obstetric scanning is absolutely the only real way to assess the antenatal period in a pregnancy. And obviously, we do thousands and thousands of ultrasounds. Just to give you an example, during the pandemic, we stopped all routine work and we came back at the end of the pandemic and said, right, how many patients have we got waiting in each modality? And in ultrasound, we had maybe 10,000 patients waiting in the last 3 months. That's a huge number compared to, for example, maybe about 1,000 CTs and about maybe 800 or 900 MRI scans. So it's it's like 10 times the volume of the other two modalities. Okay, what's happening in ultrasound is that, as the name suggests, it's ultrasound. So the sound waves are produced by a transducer, and that transducer then sends those sound waves into the body. And as the sound waves travel through the body and through the different tissues, so for example, muscle or tendon or ligament or liver or spleen or pancreas or gallbladder, they get sort of spread out in different ways. So they get deflected, some get reflected back, some get absorbed, some get sent through. And that change in what happens to the sound waves and the number of sound waves that are reflected back to the transducer allows the transducer to then create the image via something called the piezoelectric effect. And what that does is it then allows the grayscale imaging, which most of you must have seen, it looks like a snowstorm to the untrained eye, to be able to see what's going on and then decipher the different structures. You need a coupling medium. That's why we use lots of gel when we do ultrasound, and that allows the actual sound waves to transfer from the transducer through the coupling medium into the patient and then out. So it's all very good in terms of using it for abdomen, for peripheral structures, for soft tissues, for muscles, tendons, ligaments. So MSK ultrasound is huge. General body ultrasound is huge. The one problem where it's not obviously useful is, for example, bony structures. Okay, because ultrasound, all the sound waves will get reflected back from the bone because bone is so dense, and by the same sort of theory, it's not very good for lungs, because in the lungs, all the sound waves will pass through the lungs. So you'll never really get asked to do an ultrasound scan of the lungs. The only time we do an ultrasound scan of the chest really is to look for a pleural effusion. But I wouldn't assess the lungs using ultrasound. At the same time, I wouldn't assess bony structures using ultrasound. So what that means is you can't assess the brain, for example, because you can't get through the thick skull to be able to get into the brain and to be able to ultrasound the brain. And as a result of that, certain deep structures in the body you can't assess. So, for example, the menisci, which are within the knee, would be very useful in ultrasound, but you just can't get into the knee joint because of the bony structures to be able to assess those. I've mentioned all the uses in terms of MSK uses, and we do lots and lots of MSK ultrasound. I mean, in our departments, the 3 departments that I run, we do, when I started 10 years ago, we were doing 1 MSK list a week. We now do 7 to 8 MSK lists a week in each of the 3 hospitals. So the growth has just absolutely, it's just been exponential. And we're seeing more and more uses. The other thing about ultrasound, which I wanted to mention before I move away, is the ability to intervene. So to be able to do ultrasound guided procedures. So for example, ultrasound guided injections, ultrasound guided biopsies, FNAs, which are fine needle aspirations, to be able to do dry needling, barbotage procedures, all these various procedures, using image guidance to do them gives you a much better result, because you know exactly where the needle is. you know where exactly you're putting the steroid, if it's steroid, or PRP if it's PRP. So that ability to intervene, it makes it a really, really good modality, and in fact makes it a better modality than some of the other modalities like MRI and CT, where you don't have the ability to intervene quite so readily. So we and I get a lot of referrals for example, ultrasound scan of the shoulder, question mark rotator cuff tear, question mark bursitis, and then the referral will go on to say, if there is a bursitis, please do an ultrasound guided intervention, an injection into the bursa. So the patient comes for a diagnostic test, gets a diagnosis, and in the same sitting will get a therapeutic procedure as well. So that's really good for the patient, is really good for the referrer, is really good for the radiologist, because you're actually adding value to the whole pathway. And that can make a big difference from patients in terms of getting their treatment quicker and sooner. So I do a lot of ultrasound guided procedures, and I'll talk about those later. I will mention CT because it is important, though we don't offer CT in Orion imaging. It's a key part of any imaging talk if you're going to talk about which test when. So we need to understand CT and how CT works. So CT, again, uses radiation. So patient goes into the donut. You must have seen it. It's a donut scanner where you are lying on the bed, you get put into the donut, and then the scan is taken. CT is very quick. Okay, it's super fast. You can do a CT scan in about 30 seconds. Most of the time in the CT scan is taken up by getting the patient to the department, into the scanner, cannulated, get them ready, prep them, and then come out. So pressing the button and doing the scan bit is very, very quick. It's quite accessible. Every hospital in this country, NHS hospital, has a CT scanner now. There are bigger machines in terms of speed, less radiation dose, and all the rest of it. And it's an absolute excellent modality for emergency scanning. So we do lots and lots of CT scans in our hospitals, particularly servicing the A&E departments, looking for patients who've had bleeds, strokes, trauma, fractures, abdominal sepsis, intra-abdominal pathology, liver laceration, all these various things. CT is absolutely key. And as I said in the beginning of the talk, there are some complex CTs that we're beginning to do, like cardiac CT as well now. The downside of CT is the radiation dose, and I've got the number here, which is quite eye-watering, that one CT scan is like having 300 chest x-rays. That's a huge number, and people don't take that into account when they're requesting CTs. And if you were told that you're going to have 300 chest x-rays this morning, you think, oh my God, I don't really want 300 chest x-rays, so I know that those x-rays are harmful to me. Whereas people will, order or request CTs very, very easily. Just to give you a bit of idea about radiation dose, I quite like this slide because it makes people go, wow. A chest x-ray is equivalent to 3 days worth of normal background radiation. Walking around London, you get 3 days of background radiation. That's like a chest x-ray. So that's fine. Not going to worry about that. However, a CT scan of the abdomen is like having 4.5 years of background radiation. Okay, this slide is slightly old, so some of the new scanners give you a much less radiation dose, but that's still a huge number compared to, for example, 3 days. And that's the consideration that you need to take into account when you're requesting a CT scan. So you really need to be asking a question. You really need to be getting a good answer that's actually going to make a difference to the patient. And obviously, we do loads of CTs because they do make a difference to trauma. They do make a difference to cancer management, cancer treatment, cancer diagnosis, and CT saves lives. So it does save lives, but there is potentially a huge price to pay. And that's because radiation causes cancer. So up to 700 cases of cancer per year can be attributed to diagnostic radiation. Obviously, the problem is much worse across the pond in the States, where lots and lots of small scans, CTs, MRIs, everything are done. And that's something that we're seeing the direction of flow here in this country. More CTs, more MRIs, more plain fills, more ultrasound, more diagnostics, full stop in every patient pathway. There are some uses in MSK, so I wanted to touch on that because I understand most of the audience is going to be from a physio, chiropractor, osteopathic background and orthopedic background. So we do use MCT for fracture assessment. We look for bone healing. We look for if patients can't have an MRI scan, and we'll talk about that in a little while, if there are certain CT guided procedures. So for example, the facet joint injection, lumbar nerve root injections, we'll do CT guided. And then if you've got complex bony anatomy, for example, if you've got tarsal coalition in the ankle, the actual assessment of that anatomy is much better and easier with a CT scan as opposed to an MRI scan. So that brings us on to MRI. which is obviously a key component of what we do here at Orion. And it's an excellent test, to be fair. I mean, it really is. So going back to, I'll come back to my initial question right at the beginning, which is better, ultrasound and MRI, once I've talked about MRI. MRI is excellent. It's been around, obviously not as long as CT, but it's been around a long time, more than sort of 25, 30 years now. We get excellent soft tissue characterization, so fantastic. There's nothing that touches it in terms of soft tissue characterization. So being able to look at muscle, look at ligaments, tendons, menisci, cartilage, brain matter, vessels. There is nothing that can touch MRI. You can look at edema patterns, and we know that edema follows pathology. So if you bang your knee and you're bruising, you've got some bone bruising, soft tissue bruising, there's going to be some edema there. MRI is super sensitive in picking up that edema. So even a subtle injury will show up on MRI a lot more easily than it will, for example, on CT, plain film, or even ultrasound. And there's loads of uses for MRI. So obviously a huge use for MRI in MSK. So most of musculoskeletal imaging will have an MRI component at some stage. So for example, knees, shoulders, hips, spine, ankles, all of those, wrists, elbow, everything has a key, MRI has a key role in assessing those anatomical body parts. There's a massive role for MRI in neuroimaging, so brain, IMs, spinal cord. I think it's pretty much the only real way. I mean, there are CT of the brain, but to be able to really get the anatomy and the detail of what's going on, an MRI is second to none. And there's more and more uses of MRI in body imaging now. So we're doing a lot more liver MRI for complex liver problems. We're doing a lot more adrenal MRI, body MRI, looking at, as a potentially even as a screening tool. And I'll come on to that in a second, why that's happening. And one of the key areas of growth recently is cardiac MRI. So we're being able to actually assess the heart for the first time in terms of its anatomy, because echo is very good, CT is very good. However, we've never really been able to look at the heart muscle itself. And cardiac MRI is becoming bigger and bigger year on year. It's different from other diagnostic procedures because it's not radiation based, and that's the key thing here with MRI. So essentially it's safe. Now I'll come back to that caveat in a second. So there is a caveat there, so just bear that in mind. But essentially it is safe as long as the patient is not contraindicated to have one. It's using electromagnetic radiation, so you're not actually imparting ionizing radiation, which is a bad radiation, into the patient, and you're relying on X-rays. What you're actually relying on is water molecules. So most of our bodies are made up of water, and we know also that water follows pathology. So if you do injure something, there is going to be edema, and edema is the breakdown of cells and the accumulation of fluid, water. So what happens is that a patient is put in an MRI scanner. An MRI scanner is the tube, so it's not the donut. The donut is the CT. The tube is the MRI scanner. The patient lies down and they get sort of wheeled into the tube. And then what happens in the tube is that you have this strong magnetic field turned on, and then the patient is subjected to pulses of electromagnetic radiation, i.e. really strong magnets are turned on and off. When you turn on a magnet and put a patient or a person in that magnet, what happens is the protons, which are the water molecules, they are usually spinning, or what we call precessing, I've got an image here, in a particular direction. When they go in the magnet, you turn the magnet on, all of those protons are forced to spin in the direction of the magnetic field that you have imparted on the patient. So what you do is you say, right, I'm going to make all the protons now spin in this direction over here. And then when they're spinning in this direction over here, you turn the magnet off and everything goes back to the way it was. And the time it takes for everything to go back the way it was varies from organ to organ, from finding to finding. So fluid, water, liver, spleen, pancreas, all of these organs will move from here to here in terms of protons at a different rate. And that is the difference in the rate that will allow you to then create the image. And that's the image that you see. So that's very quick whistle-stop tour of MRI physics, and that's pretty much all I've really understood of MRI physics, having done my radiology training. But that's all you really need to understand. It's relatively safe. There's no ionizing radiation. You're not imparting any kind of radiation to the patient apart from electromagnetic, and that is essentially, inverted commas, safe. And you're basically looking at water molecules And if you understand that, then you can understand why you get the images that you get and why it's good for certain things and not good for other areas. So I've just said that. So what MRI does, it gives you these kind of images, which are absolutely stunning. As you can see, they're exquisite, they're beautiful. We can all see that that's an MRI scan of the brain. You get really good anatomy. You get really good appreciation of the anatomical structures and obviously any pathology that's going on. When you do an MRI scan, there's essentially two main types of studies that you need to know. And the reason why I'm going to spend some time on this is because some people will put this into their reports, that they will say, for example, there is high stir signal seen in the lateral femoral condyle. And you as a referrer is thinking, what the hell stir? And what does he mean high signal? And what's he talking about? Oh, my God, can you speak English? So what that means is, when we are referring to MRI, we talk about signal, because as I said to you, it's the moving of the photons from here to here, imparting a signal that goes to the scanner, and the scanner creates an image. That signal returned by the tissue is tissue dependent. So when someone says there is increased stir signal, it means that that tissue has got lots of signal in that particular phase, and that's what's allowing what you're seeing on the image. Now, T1 weighted and T2 weighted are the two areas you need to know. T1 weighted sequences are sometimes known as PD sequences. They're very similar, and they are very good for anatomy. So when you're looking at your MRI scan and you think the anatomy looks really good, you can really see the bone marrow, you can really see the cartilage, the ligaments, the tendons, the menisci, and I'll show you some studies in the second part of the talk. Those are usually T1 weighted sequences, and they're really good because they're good for anatomy. T2 weighted sequences, what happens in T2 weighted sequences is that fluid or water is bright. So it's very, very good for pathology. As I already said, most pathologies will have edema attached to it. So therefore T2 weighted sequences are really good for looking for that edema. And sometimes they're called stir or flare or these sort of acronyms which stand for some long-winded process. But essentially, some people will mention on the stir sequence. And what they're saying is that on the heavily weighted water sequence, there is lots of edema, which means that you can then say, all right, that's bruising or that's injury. That's what it suggests. I'll give you some examples in a little while. So T1 is very good for anatomy, looking at the brain, looking at all the joints. Is very, very good for looking at the anatomy in terms of the ACL, the PCL, the ligaments, the tendons, and to really look at what they look like anatomically. That's a T1 weighted sequence of the brain, and here you can see the black bits in the middle where the CSF spaces are. They are. I'll show you a pointer. I can get a pointer. These areas here, these should be normally full of fluid, and they are full of fluid. It's just that the fluid on the T1 weighted sequence is black. So all this white stuff here is actually fat. Okay, that's what the high signal is, and this is all the fluid. So all the fluid has been signaled out and is black. And that's a T1 weighted sequence. So you get really good anatomy. You can see, for example, on this sagittal view, you can really make out there's the tongue, there's the pons, there's the midbrain, there's the cerebellum, there's a spinal cord going down here, there's the cervical spine. You can see the vertebrae here, that's C2, 3, 4, 5, 6 intervertebral bodies there. You can see the brain, the corpus callosum here. So lots and lots of anatomy, pituitary gland there. So really good for anatomy. T2 weighted sequences are good for pathology because on a T2 weighted sequence, fluid is bright. So here we have a T2 weighted sequence now. So on the T2 weighted, so you can see that the fluid is now bright, which is really good because it really lights up here. You can see the orbits and you got all this CSF fluid around the brain. So really good for fluid. And if there was, for example, if the patient was unfortunate to have a stroke, for example, there'd be lots of edema and you'd pick it up straight away because there'd be lots of edema there. And I'll show you some images later. Proton density is somewhere in the middle, but some people use PD and PD fat sat, which is similar to T1 and stir. So I just thought I'd mention it. So if you do look at your images and you think, where's the T1 weighted? PD in essence is a T1 weighted sequence. A PDFS, which is PD fat sat, is essentially a fluid sensitive sequence. So some people use PD and PD fat sat. Some people use T1, T2, or T1 and stir sequences. So those are the main sort of types of sequences that you are likely to encounter. And I do advise and advocate that you look at the studies. So we have at Orion and a lot of the other centers, there is usually a referrer and a patient portal where you can access your images. So if you do get a scan, you organize it or request a scan, the scan is done. The more scans you see, the more you'll get used to looking at things. So I do advocate to all my referrers, whether they're orthopedic surgeons or clinicians or physios or chiropractors or osteopaths or whichever clinical specialty they do, I do say to them, look at the scans. And there's two reasons for that. One, because you'll be able to, when you look at the report and the scan in conjunction, you'll be able to see what I, as a radiologist, am pointing out to you. Your anatomy and anatomical knowledge will increase. And from time to time, it does happen, you'll catch me out. You'll say, oh, hang on a second, you've mentioned this, but what about this area here? And that's really useful for me because, you know, I'm not infallible. I might miss something. Radiologists always miss something. And also it's a better understanding. The patient gets a better experience and a better service where, you know, if we all understand exactly what's going on the studies. So people always ask me about MR arthrography, so I thought I'd just speak about it here. MR arthrography is basically a specialized MRI scan. So it's an arthrogram. And what we do is we inject something into the patient and then do the scan. There's two ways of doing the injection. So one is that you can give the patient an injection in their vein. It's called an intravenous injection, and that's an indirect arthrogram. So if you are looking for synovitis, for example, so somebody's got rheumatoid arthritis, they've got a painful knee, it's got worse recently, you want to look for flare-up of synovitis. What you would do is you do an MRI scan of the knee, and you would do a sequence at the end of the scan where you would give the patient intravenous gadolinium, which would go into the body, and if there was an area in the body which was inflamed, that would light up, and that would obviously, the knee would light up because the knee is inflamed because of synovitis, and that is an indirect arthrogram. It's good for that sort of thing. A direct arthrogram is where you actually inject into the joint that you're about to scan. So you inject into the shoulder, or you inject into the hip, or you inject into the wrist. And the reason why you're doing that is what you want to do is you want the joint that you're scanning to be slightly distended. So putting in fluid makes it distended, which makes it easier for you to identify the small structures. So for example, if you're assessing the labrum in the shoulder, or the scapholunate ligament in the wrist, or the collateral ligaments in the elbow, or the hip labrum, then to really be able to identify that clearly and, you know, work out whether there is some pathology, whether there's a tear, injecting directly into the joint with some fluid will highlight that, will distend the joint slightly, and the gadolinium that you inject will actually work its way around the joint, and if there is a tear in the labrum, it will work its way into the tear, and it will be a physical representation of the tear. And it's much better than just doing a plain MRI when you're looking for intra-articular pathology. So not pathology around the outside of the joint, but inside, particularly labrum in the shoulder, labrum in the hip, scapholunate or ligamentous injury in the wrist. Those are the three main areas, and we do quite a few arthrograms, and we do them at Orion as well, where the patient has an injection using ultrasound. So you use ultrasound to do the injection. So you guide the needle into the joint, you inject in the joint, and then the patient comes off the ultrasound table, they go across the corridor to the MRI scanner, and they have an MRI arthrogram. So you just get a much better study and much clearer understanding of what's happening in terms of arthrogram. So before I answer the question of which is better, MRI or ultrasound, I just thought I'd talk about contraindications, because all I've been saying for the last few minutes is that MRI is safe, it's amazing, MRI is wonderful, MRI is safe, it's grazing, it's wonderful. It is. However, there are some key contraindications that you do need to understand. So basically, here are the first one. The first one is claustrophobia. Now, most people will say, oh, well, that's fine, claustrophobia is not such a big problem. However, it's a huge problem. I'm not sure if any of the audience have had a MRI scan. I have for my lumbar spine. I'm not claustrophobic at all. I can get into a lift of crowded people. I can crawl into a cave happily, no issue at all. However, when I got into the MRI scanner the first time, I actually felt very claustrophobic. So I thought, that's me who's not claustrophobic. And if someone is even slightly claustrophobic, they're going to find it hard. Having said that, the scanners are getting wider, the bore is getting bigger, and the radiographers in MRI are really good at getting patients to calm down and getting their scan done. And we can use certain tactics. So for example, if we're doing a wrist, we'll put the arm in and not put the patient. If we're doing a lumbar spine and the patient's claustrophobic, you can go in leg first so the head is out. And some of the new scanners have these fancy glasses that you can put on, so a bit of VR, or mirrors where when you go into the scanner, you look up at a mirror which reflects out onto the outside, and there's a scene of the seaside or something, and it makes it a lot easier. Aneurysm coils and clips. So if you've had a brain injury in the past where you've had a bleed and it's been treated with a coil or a clip, that's a complete contraindication, because when you put the patient in and turn on the magnet, that coil or clip may move, it may heat up. If it heats up or moves, it could be catastrophic and it could kill the patient. Cochlear implants are another contraindication. Pacemaker and pacemaker wires. So pacemakers, because they can be reset with the electromagnetic impulse. However, there are MRI compatible pacemakers now available. If somebody's working with metalwork, so what they'll need is an X-ray of their orbits first, because if they have little shards of metal in their eyes and you put them into the scanner, that shard of metal will fly out and obviously damage the eye on the way out. So that by the same theory, shrapnel is obviously another contraindication. Things that are safe, though, are joint replacements, completely safe. So hip replacement, no issue at all. It's not going to move, it's cemented in. However, it gives you loads of artifacts, so it might not be useful, but it's not a contraindication. So if someone needs a brain MRI scan and they've had a hip replacement, that's fine, you can do that. Cardiac stents, which is interesting because most people say, oh, cardiac stents, there's no way you can do that because you've got a stent in your heart. The stents are put in such high pressure into the coronary arteries that there's no way they're going to move in any electromagnetic field. And a relative contraindication is pregnancy. So we don't like to scan pregnant women in an MRI scanner. However, if we really need to, we would. And there's a new field that's been developing recently in the last 5 to 10 years where fetal MRI is actually being used to diagnose antenatal conditions. So it is relatively safe, but obviously we just a little bit wary from time to time.
Should we
now
just
before I
a second just to your polls?
Yeah, let's do the poll. So before we do the first poll, let me talk about the first one we did. So which is better, MRI or ultrasound? And I think most people said MRI. I think the answer, it was a bit of a trick question, I'm afraid. It depends on the condition. It depends on what you're looking for. So if you're looking for example, even in one joint, the answer can be different. So if you're looking for example, a rotator cuff tear in the shoulder and the patient's got impingement, to be honest, an ultrasound scan, in my opinion, is better, because it gives you the diagnosis. You could do a dynamic scan and you could potentially do an injection at the same time. So that's really good. And from a health economics perspective, it's cheaper, it's more accessible, it's better tolerated by patients. So ultrasound is better for rotator cuff pathology, in my opinion. However, if you're looking for cartilage damage, labral damage, complex shoulder problems where the patient has a frozen shoulder, adhesive capsulitis, or maybe they have impingement, but you're worried about other pathology in association with the impingement, then obviously MRI is much better, because there's no way that ultrasound is going to be able to look at those structures. So that was a slight trick question, but I think, if I'd asked a bunch of medical students or even a group of radiologists, most people would have done what you did, which is that most people say MRI, few people say ultrasound, but it depends on the referral and why we're doing the scan. So we've got a few more polls for you to see.
Okay, right. Here's the first one.
Paying attention. So the first one, for assessment of the labrum. So I talked about this. So which is better, an MRI scan, an MR arthrogram, or an ultrasound? What would you do for assessment of the labrum? So somebody comes into you, they've got an instability in the shoulder, they've got some clicking, perhaps they've had a previous dislocation, and you think, oh, right, I think the patient's got a labral tear. Which would you do?
And we'll just give you a few seconds to vote for this one, because we've got 3 polls to fit in. So get your choices in quickly.
Yep.
And
I can see a few questions coming up, which are quite nice in the panel. We'll go through those, so don't worry. To the people who've asked the questions, we are not ignoring you. I will take those questions.
Yeah. Okay, let's end the voting there. So we've got, most people said MR arthrogram.
Yeah, and that's absolutely right. So in terms of pure test, MR arthrogram is better for looking at labrum, because you can, putting in that contrast into the joint will allow you to distend the joint slightly, will allow the contrast to work its way through the joint and show up the arthrogram. I think studies have shown the sensitivity and specificity in the 98 or 99% range, which is excellent. Having said that, MRI is good, and I see one of the questions that was being asked is that with regards to MRI and labral tears, we've been advised that 3T doesn't require contrast. Yes, in terms of the question is what is better, 1.5 or 3 or MR arthrogram. An MR arthrogram on a 3T is still better than a 3T without an MR without the contrast. However, 3T is better than 1.5. So you could say a 1.5T arthrogram is probably the same as having a 3T MRI scan. So that's where that's come in, and people have seen that because the contrast and the anatomy and the pathology that you can see on a 3T is more than a 1.5, particularly when you're looking at shoulders and hips. But then again, obviously, an arthrogram is invasive, so you are injecting the patient. It does have risks. You need a doctor to do the injection, so that adds in an extra process to it. And in the private sector, for self-pay patients, it's much more expensive. As soon as you put a needle into a patient, the price rockets. So in the true scientific answer, yes, arthrogram is better, much better. In terms of the real-world answer, then MRI is probably a good test to start with, because it will give you, in most cases, it will give you an answer without being invasive, without being ridiculously expensive, and you don't need that doctor and everything else involved to do the injection. Ultrasound, I'm afraid, has no role in labrum pathology. So the question did ask for labrum. You can't assess the labrum in ultrasound at all, and so ultrasound unfortunately has no role here. So next poll.
I think this is a little bit of a trick one, just to see if you were listening, because I heard
I've said the answer to this. So assessment of rotator cuff, which modality is better? I've kind of talked about this loads.
Yeah. Okay, so
just give you a few seconds.
Most people were listening.
Yeah, in my opinion, this is obviously my opinion. So you can get it is. You can get papers that will say MRI is better. You can get papers that will say ultrasound better. It depends who you ask. Obviously, from my personal perspective, taking into account, the National Health Service, the volume of work, the orthopedic surgeons I work with, the accessibility and everything, taking all of that into account, in my opinion, it is. Let's see what the poll says first.
So the poll says ultrasound.
Yeah, and that's true, because obviously ultrasound is dynamic. It's a rotator cuff. It's very accessible. Supraspinatus, subscapularis, infraspinatus, teres minor, all can be assessed with ultrasound. The biceps tendon as well. You can look for subluxation. You can do dynamic tests. You can get the patient to raise their arm up, look for impingement, look for bursitis. You can go in and inject all at the same sitting. It's very cheap. It's accessible. It's affordable. And I think, as I said, particularly in the National Health Service, if somebody is suspected of rotator cuff pathology, we will not accept an MRI request for that patient because we want them to have an ultrasound, because it's just the best way for health economics perspective. So yeah, right. So which of the following is a contraindication to MRI? So if the patient has a coronary stent or intracranial coil or a hip replacement, which of the three will stop them from having an MRI? So obviously you don't need to worry so much about this, okay? Because what we will do a health safety questionnaire. Obviously you can, because there's no point requesting an MRI for a patient if they have a complete contraindication. But from a danger perspective, we have our own processes in place where we will do a safety questionnaire before we put any patient into an MRI scanner.
Yeah.
So let's see if people were paying attention. Neem, do you want to press the button?
Yeah, there's the answers. So most people said
cranial coil. Yeah, exactly. Hip replacement is not a contraindication at all. You may not get good images, but you can stick someone in with a hip replacement straight into a scan. Coronary stent is absolutely no contraindication at all. So anyone who's had a coronary stent can have an MRI scan, and even we do a cardiac MRI on these patients for ischemic heart disease, looking for ischemia and things. An intracranial coil is a contraindication, so we will not put somebody with a coil into the scanner because it can heat up, it can move, it can cause damage to the vessel, it can cause a bleed in the brain, which would be catastrophic. Okay, I think that's all of them, isn't it? Yeah. So in summary, which test when? How are you going to decide? Well, you need a good clinical history, and that's your job. You need to see the patient. Well, in the pandemic region, you may be having a Zoom consultation. And that's quite interesting because we've seen an interesting phenomenon during the pandemic where we're getting a lot more referrals because you guys are not able to do that first step, unfortunately, which was such a key part of any patient pathway, the history and examination. Because of the lack of history and lack of examination during the pandemic, we've seen a huge number of scan requests coming through to answer questions that otherwise you would have answered because clinically you would have made the decision. Do the definitive test for the best answer. So in the past, what used to happen is that before you got your MRI scan, you'd have to have your plain film, and then you'd have to have your ultrasound, and then you have to have your CT, and only then would you be allowed anywhere near an MRI scanner. So we're doing away with that theory. So if the MRI is going to give you the answer, then do away with everything else and just do the MRI. If it's going to be an ultrasound, then do the ultrasound. You don't need to do each test along the way to get to the next test. Consider intervention. So it's better for the patient if they can have their therapy and diagnostic test in the same sitting. And obviously ask your friendly radiologist to speak to someone like me or whoever is doing your imaging for you. Which test, when, how, why, what, and what do you mean? Not just about which test when, but also what do you mean in your reports? I don't understand this or I don't understand that. As you learn more, as you understand imaging more, you'll get a lot more out of the service. I think that's, I want to talk a little bit about how to write a referral because it really helps us as a clinical radiologist to give you a much better service if the information that I'm provided with, because unfortunately I haven't had the ability to see the patient. So when I get asked to look at an MRI scan or do a report on a CT, I've just got the clinical information that you provide me. So I need all the necessary clinical information, but I need it to be succinct. So that doesn't mean I need a whole paragraph, because when I'm reporting, when I've got like 20 or 30 scans to report in a session, I don't want to read paragraphs and paragraphs of notes because that's going to slow me down. At the same time, if you say to me, knee pain, MRI scan of the knee, please, I don't know what I'm looking for. Needle in a haystack. I don't know if that cartilage damage is relevant or not. I don't know if the lateral little bit of iliotibial friction that I can see is relative or not, because I don't know where the pain is. Whereas if you say to me, lateral sided knee pain, worse after cycling, swollen, for the last 6 months. Now that's all I need. Now I know that iliotibial friction syndrome is important, and the meniscal tear on the medial side has probably been there for like ages and ages and ages. So I can then tailor my report to what you've told me. So that really helps. Make use of your clinical radiologist. As I've said a number of times, we are meant to work in partnership, and that's how we should be working, to get the best out of me and the best out of your imaging service. And that's what happens in the National Health Service. So we do lots and lots of MDTs, multidisciplinary team meetings. We have an upper limb MDT, we have a wrist MDT, we have a knee MDT, we have all the cancer MDTs, where the radiologist, the clinician, the physio will all sit down together, and we'll all come together and say, look, what's going on? Is it relevant? What's happening? Look at the imaging, look at the findings, and then come to a joint decision on how we're going to manage that patient. And it's quite nice to ask a question in your referral, because then I get a chance to answer that question for you. I think that's the end of my presentation. I just wanted to, shall I take some of these questions, Neem, just to so we don't forget about them?
I think we'll just leave them for the Q&A at the end.
Okay, fine. Okay, cool. All right, so we're going to take a break now, aren't we?
Yeah, so I'm just going to show you guys a video. It's just a little bit of a virtual tour of our clinic. And I'll put up a button at the top of the screen now. So if you want to find out why and how to refer to us, please click the button at the top of your screen, and we'll show you the video now. Qaiser, if you could just mute your mic just in case we get some feedback or an echo.
Help us to keep it safe for all at Oryon Imaging. When a patient arrives at our clinic on Wimpole Street, they'll need to wash their hands before putting on gloves and a mask, which we provide. When putting a mask on, it's important to fit it to the face and cover the nose. Patients can then head downstairs to check in at reception. They can take a seat and stay 2 meters away from anyone else, and they'll be checked in by the receptionist when ready. patient will then be taken through to have their scan by our friendly radiographers, who are issued with enhanced PPE. We have more safety measures than can be listed here, so visit our website to see them. Once the scan is complete, simply check out, throw away your PPE, wash your hands and go.
Okay, so I hope you enjoyed that. We're just going to take a short break now. So I'm just going to change the button at the top of the screen shortly. If you want to click that button, please do. And we will go on a short break for 5 minutes. And yeah, we'll be back at, so bang on 8 o'clock. We'll come back and we'll start the second half. So yeah, we'll see you then. Okay, hope everyone managed to go and grab a quick drink. So we will resume the second half. I will turn off my camera and Qaiser will start the second half.
Okay, so what we thought we'd do in the second half is make it a bit more interesting for you. So what we thought was to do some live cases. So live in the sense that real MRI cases, and go through the images and findings with you. Usually people like this part of the talk because it gets them to, I point out the anatomy. Normally, obviously, I have you with me, so I can show you exactly what's going on. So it's the first time I'm doing it on this platform with screen sharing, so I hope this works. So if I do screen sharing here, open in browser, application window. Okay, so hopefully you should be able to see that. And I'm sure somebody will tell me if you can't. So here we have an MRI scan that was done for a patient who had left-sided hip pain. So left-sided hip pain. So when you're doing an MRI scan of left-sided hip pain, there's a number of ways of doing the scan. So you can do the scan like this, where you've got this sort of large field of view, and you clearly are going to get imaging of both hips. That's very useful. I do like large field of view study for at least part of my hip protocol, because it means that I can compare both sides, and it gives me a good idea of the surrounding structures. And we all know that hip pain doesn't necessarily mean pathology in the hip. It might be pathology in the groin, it might be pathology in the lumbar spine, SI joints, and all these areas that if you were just to do a small field of view of the left hip, you would miss. Obviously, if you are looking at the left hip, you do need a further sequence, which is going to be a small field of view sequence, and I'll show you what that looks like in a second. So if we look at this study, what I normally do is I obviously try and orientate myself, and I just scroll through the study and have a look at what's going on. So just a very quick scroll through to have a look at what's going on, see if I can pick up some initial findings, orientate myself anatomically, and see if there's any obvious pathology that I'm picking up. And I'm picking up quite a bit of pathology in this patient. So if we have a look here, I'll point out some of the anatomy first. So here we have at the anterior aspect, you've got the pubic symphysis here. These are the adductor muscles. Okay, the adductor group of muscles coming off here, pubic symphysis. There would be, if someone has a groin strain or an adductor strain, it's this region here that you need to be looking. So you're looking for a detachment of those muscle fibers, any edema extending along the adductor longus, for example, any fluid extending into the pubic cleft. This is the region here for groin strains. As we work our way back, we can see the hip joints coming into view. So you've got your femoral head on one side, your femoral head on the other side. Obviously, there's something going on here. We'll talk about that in a while. In fact, there's something going on here on the other side as well. I'll talk about the pathology in a second. So you've got the acetabulum, the cup, and the femoral head here on both sides. As we scroll backwards, going through, you've got your iliac crests coming into view here and here. You've got more of the acetabulum. You can see a little bit of the labrum there and there, but we're not going to really assess the labrum on this large field of view. It's not got enough resolution anatomy to be able to assess that. However, as we scroll through, we will look at the greater trochanters on both sides. Here's the greater trochanter on one side and the greater trochanter on the other side. A key area for lateral sided hip pain. So the gluteus medius tendon, which comes across here and attaches onto the greater trochanter, can be tendinopathic, and they can be associated trochanteric bursitis, which can give you hip pain. As we're scrolling through, we come back posteriorly to the SI joints, which just come into view there, and there they are in more. You can see them more clearly now. Looking for any edema, so you're looking for any edema in the sacrum. So somebody who may have an insufficiency fracture because of osteoporosis would have edema here. They may have sacroiliitis. They might have fusion of the SI joint. So SI joints, key area to look at, particularly for hip or back pain. You need to really assess that. And as you're doing that, you can then look at the ischiotuberosities here posteriorly, and these tendons here, this black tendon here and this black tendon here, these are the hamstring tendons. And as I scroll through, you'll see the two hamstring tendons, a conjoint tendon of the semitendinosus and the biceps femoris and the semimembranosus coming off there. And you can assess that in more detail on the axial view. While you're doing that, you might as well look at the lesser trochanter, which is here. Okay, so you can see the lesser trochanter here, attachment of the iliopsoas muscle, and you can see, in fact, the psoas muscle here within the abdomen. So sometimes you might see something here, for example, a psoas abscess, an iliopsoas bursitis going across the front of the hip. There's a tendon traversing in front of the hip. to go and attach to the lesser trochanter. So an iliopsoas bursitis would be sitting around here somewhere. So you might see a fluid there, you might see a fluid-filled area there. And then while you're here, you can also assess the discs here, intervertebral discs. So you can see the lower 3 disc levels, L5, S1, L4, 5, L3, L4, and look for any edema, any end plate edema. And sometimes you might see pathology here, which is reflected as symptoms down here. Obviously, in this patient, we've got quite a lot going on in the hip joint themselves. So if we take the right hip first, which is the asymptomatic hip because the pain was in the left hip, you can see that there's this area of low signal. Now, does everyone understand what pathology, or sorry, what sequence we're looking at here? If you look here, fat is black, fluid is white. Okay, you can see fluid is white because that's the bladder full of fluid. There's all this pathology here, edema and fluid. Fluid is white. So this is a T2 weighted sequence, and in fact, it's a stir sequence. So it's a very, very T2 weighted sequence, meaning that pathology really shines up nicely, and you can see the pathology. See, there's a pathology here with some fluid in the right femoral head. This is actually avascular necrosis of that right hip joint, and in fact, there's quite a lot of avascular necrosis going on the left side, and on the left side, there's associated quite a bit of edema here, extending into the femoral head, extending into the femoral neck, and there's a small associated joint effusion as well. So you've got avascular necrosis, which is probably active on the left side, which is why the patient's got left-sided hip pain, and it appears to be chronic on the right side, because look at the lack of edema. So the lack of findings can be just as useful as the presence of findings if you're making a decision. Yeah. Now, if I look at the T1 weighted sequence, I'll try and open it so that I can show it to you side by side. There's a way of doing that. No, that's not it. I haven't used, sorry. So here we are. Okay. So if I two-weighted sequence, the T1 weighted sequence there, you can see the difference in the sequences. See how fat is so bright here, and fat is bright on marrow, whereas the fluid is dark. So pathology, very, very good on the T2 weighted sequence over here. Anatomy, much better. Look at the anatomy, the anatomical detail that you can see on this sequence here. You can really see the muscle fibers. You can really see the discs and the vertebrae and the ligaments and the tendons and the muscle fibers. And look at all this fat in the muscle here. So that is a type of an anatomical detail that you can get on a T2 weighted sequence. However, if you look at that hip joint, you can see a lot of pathology. However, it's much better seen on the T2 weighted sequence.
Sorry,
and here you can see, yeah.
Just your 2 screens won't work because it's just in 1 screen at the moment. Is any sharing?
Oh, hang on. Okay, hang on. Let me see if I can do that. I can do that. There's a way of doing that, I'm sure. Let me try and see if I can do.
It should work if you share the screen rather than.
That's what I'm doing. Yeah, that's what I'm doing. Yeah, that's what I'm going to do. I'm going to go back to Horos. Okay, can you see 2 screens now?
Yeah, that's the one.
Perfect. Yeah. So T1 weighted sequence on the right, T2 weighted sequence on the left. Fat is bright, fat is dark, fluid is bright, really good pathology. Fluid is black, but really good anatomy. Okay. So avascular necrosis bilaterally, chronic on the right side, lack of edema, more acute on the left side with an effusion, cause of the left-sided hip pain. Okay. So that's the first case. Right, okay, so here we have a scan, patient presented with posterior knee pain. So knee pain, and again, you've got a scan here. So if we work our way through, I'll take you through some of the anatomy. I see lots and lots, hundreds of knee MRI scans a year. Hundreds a month probably, but thousands a year. So I've read probably in 10 years. I tried to do an estimation the other day of how many scans I'd read, and I think knee MRI is probably the commonest type of MRI that I read, which is I will one day sit down and work out how many I've read in 10 years. Anyway, for now, so fluid sensitive, T2 weighted sequence. Fluid is white. Look at that pleural effusion. Can't see the fat. The fat is black. The marrow is black. So this is going to be very good for pathology. Now, if we bring up at the same time, let's just do it at the same time so that we can see side by side. I'll get the T1 weighted sequence. You can see here, look at the anatomy, the structure that you can even see the trabecular pattern of the femur there. You can see the cartilage outlined so beautifully here on the T1 weighted sequence. You can see the cartilage behind the patella. You can see the patellar tendon, the quadriceps. You can even make out almost every single fiber as it comes and attaches there. So it's really good for anatomy. I mean, it's still fluid sensitive, it's still very good. It's just that T1 is better. So here we have posterior knee pain. So if we're going to scroll through this, so what I normally do is I always start with the sagittal first. I always orientate my first. I find out where I am, and I use the fibula head. If you use the fibula head over here, you know that now I'm lateral. And when I'm looking laterally, I can see the tibiofibular joint, make sure there's no fusion in there. And as I work my way across, I'm looking at the lateral meniscus. It should be this bow tie appearance where the anterior horn, this black triangle, should be the same size as the posterior horn, this black triangle. While I'm here, I'll have a look at this cartilage lining. You can see the cartilage, there's no cartilage damage, I can't see any edema, and I'm just working my way through the knee. As I come through, this striated appearance here is the ACL, the anterior cruciate ligament. And there's the PCL, the posterior cruciate ligament. As I come through, I've just noticed something, but I'll come back to that in a second. And I come to the medial meniscus. Now, in the medial meniscus, the posterior triangle is bigger than the anterior triangle. So you can see the bow tie appearance is lopsided, where this side of the bow tie is bigger than this side. This is the anterior horn, that's the posterior horn. And you can appreciate that this posterior horn here is not as black as the anterior horn. And it's definitely not as black as the lateral meniscus over here. You can see that there's this sort of linear signal change, if you follow my arrow, that extends all the way down to the joint surface here. That's a meniscal flap tear. That's a tear of the posterior meniscus. Okay, you can see even on the T1 weighted sequence here, you can see the tear that's extending down there. So that's torn. Okay, so that's one pathology. Now, one thing we mustn't do in radiology is something called satisfaction of search and say, well, I found the pathology, great, I'll finish with this case, I'm going to crack on, do something else, because you want to look for anything else that might also be there. And if you were scrolling through, and if some of you were paying BDI amongst you, you might have picked up there's this lesion here. What is going on there? There's a bony lesion, it's cortically placed, it's in the posterior aspect of the femur. I still remember the first time I saw this, I thought, oh my goodness, this patient's got a cancer. And straight away, I called my fellow radiologist working at Royal National Orthopaedic Hospital, a bone tumor expert, sent him a picture on WhatsApp and said, found a bone cancer in a young patient, look at this. And he turned around and said to me, no, this is a benign lesion. Some of you may have heard of it. It's called a Bufkin's lesion, B-U-F-K-I-N. And it's basically a cortical irregularity that occurs at basically the origin of the medial head of the gastrocnemius. So the gastrocnemius muscle comes off the medial femoral condyle posteriorly here, and as the muscle comes off, it's thought to be due to continued sort of traction apophysitis here, which causes this lesion. It's a completely benign lesion. You don't need to do anything about it. It sometimes causes symptoms, so you might want to offload it or do some sort of steroid type injection over here, but it's essentially a benign lesion, not cancerous. On the axial view here, you can see the cartilage lining the undersurface of the patella so beautifully, and you can see that there's this effusion in here as well, fluid there. You can assess the quadriceps tendon, the patellar tendon, look at Hoff's fat pad here, look for any evidence of anterior impingement here. On the coronal sequences, so if I get up a coronal sequence here, that's when you assess the collateral ligaments. There's a medial collateral ligament and the lateral collateral ligament, which is slightly off plane. So the medial collateral ligament you can see in this plane, and you have to kind of scroll backwards slightly, just go back a couple of slices, and then the lateral collateral ligament comes into view. And usually you can't see the lateral collateral ligament in one slice. You can see a bit of it coming out here. You can then go on to the next slice, a little bit more coming out, and then you go posterior a bit more, you can see the rest of it coming out. Whereas a medial collateral ligament you can see in one complete slice. There it is. Medial collateral ligament. Lateral collateral ligament you have to assess over 2 or 3 slices because of the way that it sort of it goes backwards from the fibular head to the lateral femoral condyle. Again, you can look at the menisci as well. Coronal view is really good for assessing the meniscal root. So there's a lateral meniscus, and look at the root here, attaching it into the tibia, and you can see it nicely there. And again, the medial meniscal root you can see here as well. The medial meniscus, there's the tear that we saw on the sagittal view, and there's the meniscal root attaching nicely in there. So there's no meniscal root tear. There is some edema here, which is the region of the iliotibial band. So we often see some edema deep to the iliotibial band. So your history is quite useful if the patient has lateral knee pain or not, but I usually mention that because that might be something that's causing the patient some symptoms. So that was a quick stop through a knee. I'll show you another knee while we're on knees because I've got another interesting knee. I'll stop
Might have to just stop you for the questions because it's
Oh,
getting,
yeah.
we're
Okay, fine.
running over
Yeah, we'll
time.
stop. Yeah, I'll keep
That's all
going. I've got enough cases to go for another 3 or 4 hours.
Here's your
So,
first one.
okay, with regards to CT and MRI, hang on. What are the potential consequences relating to contraindications and effects for 1, metal, e.g. titanium, and 2, when having taken pre-medical history notes which suggest that the patient is in cancer remission? Okay, so the first part, metal, it depends where the metal is. So if the metal is in a hip replacement, coronary stent, any of those, a screw in the wrist, a screw in the tibia, that's all fine. Not going to move, no issue at all. If it's metal in the brain, so the patient has a coil, you can't have it. If it's metal in the eye, because they work with they're in a welding profession, for example, you can't have it. If there's shrapnel in the knee, or sorry, in the leg, you can't have it because it will move. If it's a pacemaker wire or a pacemaker, again, you can't have it because it will heat up the pacemaker wire unless it's MRI compatible. So titanium per se, depending where it is, a titanium plate in the wrist, for example, is safe. Okay, the only thing to say is that it will cause artifacts. So if you are scanning the left wrist and there's a metal plate in the left wrist, you will get a lot of artifacts. So you might not get back as detailed a report as you would or were expecting because there's so much artifact. And when taking a pre-medical history notes, which suggests the patient in cancer remission. Well, cancer remission is not a contraindication for MRI, and having cancer is not a contraindication for MRI either. MRI doesn't cause or cancer. In terms of CT, again, it depends on the information you're trying to ascertain. Sorry, I didn't answer that for CT in terms of metal. Again, all metal is completely safe in CT because it's ionizing radiation. It's just the artifact that will distort the images. When it comes to cancer, yes, CT scans obviously give ionizing radiation, and we must worry about that. However, if someone's got cancer or is in cancer remission, their lifespan is already reduced. So therefore, the information that you're going to get from a CT scan is only going to prolong their life. So there is very little contraindication to do a CT scan if there is a specific clinical question you need to answer in oncology patients. And we do loads of CT in oncology patients, absolutely loads, in people in remission to make sure they are in remission. And the information that you can get potentially for doing a CT scan for someone in remission who has a recurrence is much better than the risk of them having the CT. In MRI, there's no contraindication at all for someone who has cancer, had cancer, or never had cancer. It's not of any consequence. You got another question there? Okay, I've been advised that if a patient has had a previous surgery, e.g. lumbar spine decompression, that we need an MRI plus contrast. However, I've also been advised it's not necessary post-spinal surgery to check for further new pathology. It depends on the timescale. So if you are looking for, if someone has back pain or neurogenic pain or cauda or something like that, and they've had surgery which has been more than 2 weeks and less than a year, then you give contrast. And the reason for that is because what you're trying to ascertain is that if there is something there, is it disc or is it scar tissue? Now, if it's scar tissue, after 2 weeks, and before 2 weeks, everything's going to light up because of all the trauma of the surgery. So there's no point giving contrast to anyone who's just had surgery, because you're not going to be, the contrast is going to light everything up and you're not going to be able to differentiate anything. After 2 weeks, the effects of the surgery should be decreased enough that if there is something there, you will be able to work out whether it's a disc, a new disc herniation, or whether it is scarring. That is, so if there is scar tissue, the scar will light up for 1 year. If, however, you get past that 1 year and someone says, I had surgery 5 years ago, I've now got back pain, I think my disc has come back, at that point there's no point giving contrast because the disc and scar both will not light up in contrast, so you won't be able to differentiate between the two. So we give MRI plus contrast if there's 2 weeks after surgery and within the first year. After the first year, there's no point. So at that point, you have to clinically treat the patient, look at the previous scan, assess what was there before they had the surgery, work out whether what's there now is a new disc or whether it's scarring, and kind of make a judgment call on that. So when I refer a client for ultrasound of the shoulder for bursitis, can I also request, if positive, to have an injection done there? Yes, that is absolutely fine. Yeah, absolutely, you can. Costs, I don't know, to be honest. It is more expensive, but we can discuss that with the patient. Obviously, it's a lot easier for self-pay patients. A lot of self-pay patients say to me, oh no, if I need an injection, can I just have it? I, as a radiologist, can't make that decision, and there's two main reasons for that. One is because it's not my patient, and you as a clinician might want to try something else first because it's your patient, so you might not want to give any steroid injection. You might want to try physio, etc., etc., etc. The second thing is, it's very important for me to remain impartial in these decisions, because you could accuse me that I'm profiteering out of this. Oh, they've had an ultrasound of the shoulder, I think you need an injection, and now I'm going to get paid for the injection. So I wouldn't make that decision. I would make that recommendation to you. However, if you give me the permission and say, if positive, then go ahead and do the injection, then I can have that discussion with the patient, and we can then have that discussion at the time. It will cost more. I don't know how much more, but we can get back to you with that after this presentation. I worked for a few years in chronic pain services as well as outpatient NHS MSK. So how do you decide on the significant findings of MSK scans, given that majority of normal people will possibly have significant degenerative? Yes, so it depends on the clinical presentation. That's why I said with my referral, your role in what you get out of imaging is absolutely key and essential. If the patient has, for example, lateral knee pain, and they come in and they've got degenerative changes in the medial joint compartment, and they've got a tear of the medial meniscus, and they've got iliotibial band friction syndrome or edema in the lateral collateral ligament, that clinical history is going to be essential for me and for you to decipher what I find. So I'm still going to present everything I find on the scan. However, I'm going to cater to what the findings are, and you're going to take the scan and say, well, look, I know that this patient got medial meniscal tear, but he's got no symptoms in the medial meniscus. So that's fine. So we'll leave that. It's the lateral side that we're worried about, and this is the cause. So it's all to do with putting together the clinical and the imaging together. We don't treat scans. That's important. I always say that to people. We don't treat scans, we treat patients, and you treat patients. Scans are there to aid the treatment of the patient. So always remember there's a patient at the center of all of this. You must take the imaging and what the imaging findings are and relay them onto the patient to be able to identify which of the findings are significant and which aren't. And you're absolutely right. If you were to take a bunch of normal people, inverted commas, normal people from the population and scan them, which has been done, obviously MRI and ultrasound being safe, you will find lots of insignificant or incidental findings. And what is the significance of those? You go back to your patient. Also, what do you make of studies that have found that there is a large variation in reporting MRI centers between centers? During a study day last year, one of our pain consultants presented an article which showed that an MRI showing a lumbar disc herniation was sent to 10 different centers for reporting and came back with 10 different results. Is this it's interesting. Yeah, I mean, yes and no. I don't think. I mean, maybe that's I wouldn't expect there to be 10 different results. I would expect certain variation, yes, between between radiologist and radiologist. What I would say about that is 2 or 3 things. Number one, there has been a lot of call for standardization of reports, and in the States, for example, there's a huge amount of standardization because what they're trying to do is they're trying to make reporting of scans a very scientific process. And there is science, yes, it is. However, as a clinician and as a radiologist in this country, we are taught to provide an opinion. So obviously my opinion will vary from another radiologist's opinion, and I might use language that's different from another radiologist. So the important thing here is to make sure that you as a clinician understand what your radiologist or the center that you're using, when they say something, what that means and what are they actually talking about. So the closer relationship you have with the radiologist, the more you see of a particular radiologist or a particular style of reporting, it will allow you to then understand. And that feedback process is very useful. So I've developed my career in the last 10 years, and it's changed a lot, where I've realized certain things are not as important as other things, to focus really on what the clinician requires from my reports and trying to make them succinct, pithy, but without missing things out. But you're right, there can be variation. So it's important to trust who you're getting your scans from. And there is, unfortunately, a huge variation in the number of radiologists, different types of radiologists, and good radiologists and inverted commas, not so good radiologists. I recently came across an MRI report that the cervical spine with the radiologist highlighted the presence of several perineural cysts adjacent to the exiting nerve roots. Patient hasn't got any ridiculous symptoms. However, I'm wondering what should be the management of those cysts based on you. So, without seeing the scan, without obviously knowing anything about the patient, if they're asymptomatic and they've got some cysts, I would probably ignore them. Okay, because the cysts arising from synovial cysts, there could be synovial cysts arising from the facet joints. If they're not causing any compression and they're not causing any ridiculous symptoms, they're not causing any pain, then a cyst, I wouldn't touch it, and I won't go anywhere near it, and I wouldn't re-image it unless it causes some symptoms, unless there's something sinister about those cysts. So obviously, if they've got some solid component, or they're growing inside, or they're causing impingement, or there's some associated edema around that region, for example, then I'll be a little bit more worried, and either I would repeat the imaging at some point, or I would refer to the neurosurgeon or neuro spine surgeon to see what they want to do about it. But without symptoms, and if they're simple, pure, true, simple cysts, I would leave alone. If a patient has query hip pain, OA, would you have a pelvis MRI scan, as there may be other disc growing pathology, especially in bilateral and especially as bilateral and automatic for a sport with man growing, the diagnosis would be better. Yeah, I guess. I mean, I guess it depends on the age of the patient. Depends what you're going to do with the patient. If you've got an elderly patient with hip pain and you think they've got osteoarthritis, a plain X-ray would probably be enough, because you want to make the diagnosis, you confirm the osteoarthritis, and then you want to decide how bad is it, and are you going to refer the patient on to surgery, or are you going to treat them conservatively? And it depends what they want as well. If you've got a younger patient who's got hip pain, or somebody who's older but very, very active, then yeah, it might, an MRI, pelvis MRI is useful, because you see both sides. You're going to be able to see the degenerative change, and as you said, you'll be able to look at all the surrounding structures, so the muscles, the adductors, the trochanters, and all the things I mentioned, the SI joints, and even you get a little sort of freebie of the lower lumbar spine as well, which can be quite useful to see what's happening with those discs.
Okay, perfect. Thank you, Qaiser. I think that's the last question. So good timing. We'll just end there. So just to wrap up, please leave us a Google review. I'll just put a little button at the top of the screen. So if you want
can I do that as well?
Yeah, of course. Please do.
I'll review myself.
So if you want to rate Qaiser, and Qaiser can rate himself, please click the button at the top. Thank you very much, Qaiser. That was really good talk, really interesting. So I hope everyone enjoyed it. We'll be sending out your CPD certificates tomorrow if you're an AHP, along with the slides and the recording of this webinar. So have a look for that in your emails, and check your junk mail just in case. So I think that's about it from us. Me and Qaiser will just turn off our cameras and mics and just leave the the review button at the top of the screen there for a few minutes.
Fantastic. Thank you very much, everyone. Thank you for listening, and thank you for the opportunity, Orion, and hopefully we'll be able to do more of these in future.
Yeah, definitely. All right. Thank you very much, everyone. Have a nice evening.